Hello and welcome. So this is a presentation on IV cannulation and ultrasound cannulation, and it is a pre-course learning video so that you can watch this video and then come and practice ultrasound cannulation in our workshops. So I'm Sean, I'm a CT3 anaesthetic trainee at Darent Valley, and I'm being helped by Rania and Wura, who are education fellows at Darent Valley. Here's our emails if you want to get in touch. So why are we doing this talk? We've all been in this situation. I have been in that situation when I was training as an FY doctor, and I want to get rid of it. There's no reason why anyone that's competent at cannulation can't also learn ultrasound cannulation. I learnt it in, I think, F3. I saw it first in F2. We've all seen it on the wards and been amazed at that difficult patient to cannulate, and then the anaesthetic reg or ED reg comes along and fires in a cannula under ultrasound. You can learn this skill, and through this video you're going to also learn some tips on how to improve your cannulation, so hopefully you don't need the ultrasound. And I can tell you that colleagues and patients, they love it, because it studies have shown it greatly improves your first pass success rate. So what are our learning objectives? Hopefully this is going to be under an hour long. At some points I'm going to talk quite quickly, and then if you need to pause it and go back, you can do so, and hopefully cut down on the waffle. Our 6 learning objectives, we're going to firstly go over some important points about volume resuscitation, choosing your cannula, what affects IV flow rate. We're going to talk about how you can improve your confidence and competence in peripheral venous cannulation. We will talk about why and how you would use an intraosseous device. Then we're going to pause and have a little break for 5 minutes, come back and talk about the basic function of ultrasound, how we can safely do ultrasound cannulation, and then talk about how you can go forward and practice these skills working towards competency. I want to be clear that at the end of this, you should know all of these things, and it should arm you to go forward and practice ultrasound cannulation in a supervised manner. I'm not expecting you to come out of this presentation and the workshops that we're arranging at Darent Valley being competent to do it on your own. So firstly, let's talk about volume resuscitation. For me, there are 2 different types of cannulas. There are ones that you can give fluid and drugs down, and there are ones that you can volume resuscitate with. So the ones that you give fluids and drugs down, it doesn't really matter how quickly you can give fluids down it. So these are blues and pinks. Whereas patients where we need to get a lot of volume into quickly, and we'll talk about the factors that affect that in the next slide, those are greys and oranges. There's a consultant at Medway who calls the green cannula the cannula of indecision. So what are some things that will reduce the rate of volume resuscitation? So you've got a hypotensive patient, let's say their systolic is 70, they're tachy at 140, they've got 2 litres of blood around them on the floor. You could see this on a medical ward with an upper GI bleed. We're more likely to see hypovolemic shock in theatres or in trauma and obstetrics, but you will occasionally see medical patients that are truly hypovolemic. And things that will slow down your rate of volume resuscitation are the Baxter pumps, the blue cannulas, and the IV ports that the nurses like to put on. I think these are one-way valves. So I remember as an FY asking for fluid boluses, and the nurse would say, okay, sure, and they push up the rate on the Baxter pump to 999, and that sounds like it's going in fast, but actually when you think about it, a litre an hour is only 17 mils a minute, which is not very fast at all. Secondly, the cannulas on the back of the packet, and we'll talk about this in the next slide, it tells you how fast they go under gravity alone. So a blue cannula, if you just hang a bag of fluids up, will give you 35 mils every minute, which is not a great amount when we talk about how much volume we're actually trying to put in. This table up here will be known to surgical trainees and people that have done ATLS. These are the 4 stages of hypovolemic shock. And you can see in the first row, this is the amount of blood loss. So the typical adult has got 70 mils per kilo of total blood volume. So for me, 70, 80 kilos, that's 5.5 litres. you can see that if we've lost less than 15% of that, which is just under a litre, you won't have any physiological change. The first thing that changes is your respiratory rate goes up. But as we progress into stage 3, when you've lost 30 to 40% and maybe a litre to 2 litres, and that is possible with the upper GI bleed, where they're vomiting up bowls of blood, they're going to be tachycardic, they're going to be hypotensive and possibly confused. And at this point, you need to get in a litre to 2 litres quickly. That is not achievable with a blue or a pink cannula. The first place that anaesthetists become aware, perhaps, of the need to quickly volume resuscitate people is in obstetrics, where at term, the uteral placental flow rate can be up to almost a litre a minute, so they can exsanguinate very quickly. And lastly, I just wanted to touch upon the question of fluid responsiveness. Now, this is something that you learn during medical school. In your OSCE, the first approach to someone who's hypotensive is to give a volume bolus. How much do we give really depends on what their cardiorenal function's like. If you've got somebody with end-stage CCF, you don't want to plumb a litre into them quickly in case it all goes to the lungs. And it's a question in the literature. There are many, many different ways to assess volume responsiveness, but really what we're doing is assessing where we are along this Frank-Starling curve, which will be familiar to you from medical school, which really shows preload and diastolic volume versus stroke volume, which is a surrogate of cardiac output. Remember, cardiac output is stroke volume times heart rate. So what we're really asking is, if we increase our preload, do we get an increase in stroke volume? So here we're on the volume responsive part, and here we're not. So if we give a fluid bolus here, we're not going to get a rise in stroke volume. So that's really what we're doing when we're assessing, is someone fluid responsive? However, let's say we're in ITU and we've got invasive monitoring in, we've got art lines, we've got cardiac output monitors. We can see that change. You can give a fluid bolus very quickly and you can see the stroke volume, cardiac output go up and the heart rate go down. However, you might not see that on the ward. It's often a transient improvement. For some reason, I always thought that you could measure urine output and then that would get better in the 5 minutes. Like, obviously it doesn't. So if you measure your non-invasive blood pressure and then you measure it again 5 minutes later after you've given that fluid bolus, you might miss the improvement in blood pressure. And lastly, something that is loved in intensive care is the passive leg raise. This really works. So in your legs, you've got about 300 mils of volume that you can quickly put into the circulation, and it's reversible. So you can take it back out. That litre that you put in that sends the elderly frail patient into pulmonary edema, that's not going to happen. So this is the way that you do a passive leg raise properly. They're sat up at 45 degrees and you sit them down and raise their legs simultaneously. Okay, so that's volume resuscitation. So now let's talk very quickly about flow rates and the facts that govern it. So this equation initially looks quite intimidating, but it's got some important points and we're going to break it down. So the most important factor governing flow rate, i.e. the number on the back of the cannula packet that tells you how quickly the cannula can go, is the radius. This equation says that the flow in litres per second is equal to or proportional to the radius to the power of 4. So what does that mean? It means if we double the radius, we will 2 to the power of 4 times 8 the flow rate. So if you were getting a litre a minute from one cannula and you double the radius, you're going to now get 8 litres a minute, which is why there is such a big difference between your blue 22 gauge, which only does 35 mils a minute under gravity, versus an orange, which is 240, and a grey, which is 150. Okay, this is known as Poiseuille's law. This is Poiseuille there. Other factors that we can mention is the length. Now, some people think that in order to volume resuscitate someone as quickly as possible, they need a central line, and that is just not true. If you can see here on the left, the equivalent green port, the 18 gauge on this central line, is slower than the blue cannula, and that is because of its length. Central lines are often 16 to, I think, 18 or 20 centimeters long. And you can see here that flow rate is inversely proportional to length. As we get longer, the flow rate goes down. Other factors, viscosity, we can't really change that, but pressure we can. So this is a level 1 transfuser. We see them in obstetrics. It's essentially a pump that warms the fluid up, and it can put in significant volumes very quickly. Often you need one person dedicated just to manage the fluids going into it. But I want to tell you that you can make one of these. You can adjust the pressure on your volume just by using a high drip stand, put it all the way up, increase the potential energy. You can put a pressure bag on. So traditionally you'll see these in ED on arterial line bags because they have to be pressurized, but you can put them on a bag of fluids, and that saves you from having to squeeze the bag. But my preferred method, as well as using those two, is to use a 3-way stopcock and a 20 ml syringe. So you can just put the 20 ml on, open the 3-way tap, draw up some fluid, close it, push it in, open, close, push. And in that way, you can get a lot of fluid in very quickly, even through a pink cannula. Okay, so those are the factors affecting flow rate. Now, just to talk about some tips on cannulation. Briefly, anesthetic training significantly improves your cannulation technique because we often have to cannulate difficult people. They're nervous, so they're peripherally shut down, they're dehydrated. The consultants often insist that we go in the back of the hand so that if we fail, they can work their way up proximally, and we get called to come and do difficult cannulas. So I'm going to share with you the tips that I've learned, and then hopefully you won't have to use the ultrasound. Okay, so the two things really are about increasing volume in the vein and increasing venodilation. So I will do 1, 2, and 3 every single time a patient comes into theatre for a cannula. I'll put a tourniquet on early. The longer you leave it on, the bigger the veins are going to get because it's just longer obstructing the venous return, and the veins will get bigger. There was a study that I looked at that showed if you put 2 tourniquets on, so one up in the armpit, one in the ACF, even greater. I'll get them to do a muscle pump and hang their hand down. So hand down below their heart and pumping away. And then the last thing that we do that I only really seen anaesthetists do, and it really works, is tapping the vein. So, you know, you don't have to, you're not going to hurt them. Obviously, you're not going to smash the hand, but firm tapping for about 10 seconds, and it really does cause the vein to vasodilate and come up, and it's because of histamine release. Other things that can be done, if you need a big cannula in the ACF and you have a small cannula in the hand, you could put a tourniquet on and give a 20 ml bolus, and that's going to get trapped in the ACF and it'll make the ACF vein bigger. We can cause some venodilation by doing a warm compress. I've done this recently to great success. You get a glove, put some hot water in it, tie the glove off, wipe the glove down because it's now going to be wet. You don't want scalding hot water that comes out of the NHS taps, but warm water, and then just put it on their hand and ask them to put another hand on it, and leave that there for 5 minutes. When you take the glove off, the whole hand is going to be bright red, and the veins are going to be bouncing out at you. Other things that cause venodilation are IV anesthetic and volatile drugs. So this is why patients who may have been difficult to cannulate, they come to theatre, and then when they come back, they've got a grey in. It's because the drugs that we've given them make their veins bigger, and also they're asleep. That's a trick. Don't tell anyone. Trick of the trade I heard from a paramedic, I've never tried this, is GTN spray. You could see why that would theoretically work for venodilation. However, you'd be surprised at the amount of GTN in one sublingual spray, and it can be absorbed topically. So I would avoid it. And then we have Amatop. So this will be known by the pediatricians. Amatop is a local anesthetic that causes vasodilation as well as numbs the skin for kids. There is another one called EMLA. EMLA is slower and it doesn't cause vasodilation. So perhaps the most important part in getting success from your cannulation is about the technique of how you actually insert it. So here are some tips. For some reason in medical school, we're taught that you go in at 45 degrees. And when I've let medical students cannulate me, they come in like a B-45 bomber. That's not what you want to do. If you can see a vein, it's very superficial, it's going to be flat. So you need a very shallow angle. So I'm saying 10 degrees at the very most. When you've tried to cannulate that elderly lady with the wobbly veins, and you put the needle in and the vein says whoop, It's because you haven't tethered and stretched the skin. So I would pull down with my thumb and pull down quite hard, and it stops the vein from wriggling around. Now, if you can, try to get used to putting the cannula in and then sliding the plastic off with one hand so that your other hand can maintain that tethering throughout. Now that's difficult, and it's only something that I've recently got much better at. You know, down, flat and in, and then you can sort of push the hub of the cannula in while holding the needle. It can be a one-handed technique, cannulation, and it allows you to keep the tethering on. But perhaps the very most important part, and this is why, if after you've gotten your first flashback and then you try to advance the plastic cannula and the patient complains, that's very painful, or you find that you can't advance it, or you finish your cannulation and now there's no blood coming out, or you don't get the secondary flashback up the plastic tubing, is because the plastic hasn't ended up in the vein. And that is generally because you need to improve your technique. So what are we doing when we're doing peripheral venous cannulation? I think of it really as kind of like a mini Seldinger. So we're putting a needle in and then we're threading a plastic tube over it. So what happens when you get your first flashback is the bevel of the needle is inside the vein. But it's important to note that the needle sticks out in front of the plastic. And you can see it here on this orange, that the actual needle and the bevel is like 5 millimeters in front of the plastic. So the reason that we teach that you have to flatten and then advance is that you also have to get this plastic bit inside the vein before you advance the plastic. So just to go over that again, once you've got the needle in, you have to flatten and advance so that the plastic actually gets into the lumen. Because if you have just the needle in and you try to advance the plastic, well, it might not be able to go through the vessel wall and you might blow the vessel, or even worse, in between that movement, you might pull the needle out a couple of millimeters, and now there's no way that that mini Seldinger technique is going to work because the needle is not in the vein anymore. Why flatten? Well, you can see that if you continued even at your very shallow angle, and this is why a shallow angle is important, if you just continued without flattening, then you're just going to come out the other side of the wall. And you're going to back wall the vessel. And so your needle tip will be here. And when you thread the plastic cannula, your cannula is going to end up down here. And then you're not going to get your secondary flashback into the plastic tube. All right. So that's something that's really important to really understand. And if you have to go back and review it, I think this will be the main thing that you could get from this cannulation tips first part of the lecture is that. All right. And it also illustrates why it's more difficult to put in bigger cannulas. So the amount of needle that is poking out of an orange is more than the amount that's poking out of a blue or a pink, which is why the bigger cannulas, the greys and the oranges, are harder to put in. There's a tip that you can see on YouTube for putting in large cannulas where they talk about lifting up the vein. So if you looked on this needle here, the sharp bit, the cutting bit, is this point here. This flat edge and this non-acute angle here, they aren't sharp, and you can run that cannula, the top of it, along your finger, and you feel it won't cut. So what you can actually do in order to advance and get all of that needle and plastic hub in is actually try and lift up a big vein with the orange cannula, and you won't come out the top of it. You manage to slide the whole thing in, which is pretty cool. All right. Other tips, if you can't see a vein, you can look in other places. In neonates and chubby infant hands, everyone seems to have a vein in between their 4th and 5th metacarpal. IVDUs will often tell you where to go. If you've got a very edematous hand, you can try and milk the edema out. On the topic of breast cancer, every patient that's had an operation on their breast seems to think that they can't have a cannula put in. That's not true. The reason that you can't cannulate an arm that has had, say, a mastectomy or an axillary clearance is that they don't have the lymph nodes there anymore. So if you put a liter of fluid in, they're not going to have that lymph clearance, and they're probably going to get lymphedema in the hand. But a sentinel node biopsy and a wide local excision are not axillary clearances. And it's also important to note that in an emergency, it's still vascular access. CT contrast, you need a biggish vein because contrast is an irritant, and you need at least a pink cannula because the pumps that they use to put the contrast in, they'll have a pressure alarm. So if it's trying to get through a really small cannula, the pressure alarm will go off and it won't work. But it doesn't need to be a 20 gauge, a green cannula, an 18 gauge in the ACF. If you've got big forearm veins, you can put a pink in there, that's fine. Alternate methods, ultrasound, we'll talk about that. IOs, we've talked about that. In an arrest situation, some people will put a big cannula in the external jugular. And in pediatrics, I like this tip. They have these things called the red lights, vein finders. They're often expensive and difficult to find, but a cheaper version of that is just a red bike light, and you get them to hold it. Fine, IOs. So when would you use an IO? The rule from Resus Council is if that you failed twice in emergency, just put an IO in. You're going to find the IO on the arrest trolley, and you will get to practice it once in ALS. So that's why I put it in this talk, to go over some of the points. A IO in your tibia is almost as good as a blue cannula, and in your humerus it's a bit faster. It's almost as good as a pink cannula, but it needs to go under pressure because it's harder to go through. If you've ever tried bolusing something through an IO, you'll know what I mean. So if you can hang a bag of fluids up in an arrest situation and all you've got is an IO, you need a pressure bag. When wouldn't you want to put an IO in? Well, if you've tried once and you failed on that bone, unfortunately you have to give up on that bone. If they have overlying infection or fracture, or if they've got some sort of brittle bone disease, osteoporosis, then you can't, because you might fracture the bone. Interestingly, they can be put in awake. And on the next slide, there is the Easy IO app, which shows you how to put in IOs. And it also, there's a demonstration of them putting it in an awake volunteer. He's probably been paid for it, but using their method, they put it in and then they infuse some lidocaine down the IO, leave it for a couple of minutes, and then they bolus down it. It's said that the painful thing is not so much putting the IO in, it's the volume expansion within the bone canal, the medulla. I can't remember the exact name. That's the painful bit. So they say to put 4 mils of 1% lidocaine down it. Now, some of you will be recalling in horror, you can't put lidocaine into the systemic circulation. Well, that's just not true, because we do it loads in anesthetics, actually. In fact, some people get IV lidocaine infusions, and it's often a pre-med given in America. What is important is that you don't go over the safe dose. So for an adult, it is 5 milligrams per kilogram, which is almost 400 milligrams. And a 1% solution, you just add a 0 next to the percent. So 1% is 10 milligrams per mil. So 4 mils is 40 milligrams. So it's a tenth of the safe dose, which is absolutely fine. Where you want to be careful is injecting into an artery. So if say like we're doing a CVC, and instead of putting the lidocaine around the IJ, we accidentally put it into the carotid, that's going to shoot off to the brain, and that would be very bad. Okay, I'm not going to go over how to put in an IO. You guys can see that on the Easy IO app. Same for the humerus. There's a specific way of adducting and internally rotating and then feeling up the arm. You do that so that you don't hit the biceps tendon here, and you go in at 45 degrees so that you don't hit the growth plate. If you want to know about how to put it in, just get the Easy IO app. But I will just quickly talk about sizing up an IO needle. So there are 3 different types of needle that come with the IO. There is easy to remember, PEDS is pink, humeral is yellow. I just think of the bone color, for some reason that works for me. And then in the middle, you've got blue. So the way that you size them up is, before you've even drilled, you connect it on, it's got a little magnet, and then you put the IO gun in, and the needle goes through the subcut tissue, through the fat, and then it hits the bone. At this point, you need to make sure that you've got at least one black line visible. You know, you could have 3 black lines, that's okay, but your IO is going to be hanging out, so it's probably not appropriate. Similarly, let's say you tried to put the blue in a large male's tibia and you don't have any black lines visible, well, that's inappropriately sized and you need to go to the yellow, right? Thick here, yeah. How to put them in, essentially you hit the bone and then there's a drill. You start drilling with a little bit of pressure and then it will take, just like anyone that's tried to put in, you know, put up some shelves. You don't need to keep going all the way until the IO is flush with the skin. Once there's a give, that's you're in, you stop drilling. If you keep going until it's all the way flush with the skin, you might come out the other side of the bone. And then you aspirate, and if you get some bone marrow, you're in. Okay, so lastly, just to touch on ultrasound, why learn ultrasound? You're probably all here not to hear me talk about how you can improve your cannulation technique, but to learn about ultrasound cannulation. I think ultrasound is the future. I'm a big enthusiast of it. I think everyone coming out of medical school in 5 years is going to be competent at ultrasound. There's a study comparing cardiologists with a stethoscope versus medical students with ultrasound, and the medical students outperformed in terms of picking up murmurs. So there are multiple things that ultrasound can be used for. It can be used in ALS to pick up cardiac activity, P's, tamponade. We can find the cricothyroid membrane. It's more sensitive than clinical examination and X-ray combined at picking up lung pathologies. So it's almost 100% sensitive at picking up a pneumothorax. And it also picks up things like pulmonary edema and consolidation. C, you can look at the IVC volume to give you an idea about how well filled they are. You can also pick up aortic dissections. D, we can look at things like papilledema. You can look at the optic nerve sheath diameter, which is a surrogate of ICP. And I think that's probably a lot easier of a skill than ophthalmoscopy. E, we can look at fluid in the abdomen, things like FAST scans. Here's some blood in between the liver and the kidney. Looking at DVTs, sending a patient down to ultrasound for a query DVT. You know, it's quite easy to look at a clot on ultrasound. It looks like echogenic tissue that you can't compress. It is very important to point out that even though you're learning these skills, it is rule in rather than rule out until you're competent and signed off. And there are different levels of ultrasound training that you can do and get official accreditation. So just because you've put an ultrasound probe on and you can't see a thrombus or a non-compressible vein doesn't mean they don't have a DVT, but there's nothing stopping you from grabbing the ultrasound in that person with an obviously swollen unilateral leg, putting the probe on. Oh yeah, look, there's a massive clot in their proximal femoral. And L, lines. So that's really what we're talking about, difficult IV access, but I also use it for, you know, art lines, things like that. So here's when we're going to take a 5-minute break and just to quickly tell you about this book. It recently came out and I think it's a great introduction, ultrasound for the generalist. Cool. So let's talk about ultrasound cannulation. When would you do it? So if they're difficult, essentially. So that could be the chemo patient, sickle cell, vascular paths, edematous, obesity, or you've failed. I will traditionally go to it after I've failed 1 or 2 times now. Contraindications, burns, overlying infection, injury. You need to be careful in the patient with end-stage renal failure because they might be saving the veins for a fistula. And what are the complications? Well, it's the usual stuff: failure, pain, bleeding, infection. But there are some other things that we need to be aware of, such as nerve injury, artery injury, and they're more likely to tissue. We'll go over that later. So you need to be careful about what things you put down it. So to talk about the physics of ultrasound, in brief, essentially an ultrasound probe has got a fancy crystal in it called a piezoelectric crystal, and that turns electricity into sound waves. The sound waves go down, they reflect back up, are interpreted by the crystal and turn back into electricity, and the machine makes a nice image. There are things that are hyperechoic, that reflect sound waves well, and these are things like bone, and they appear bright white. This is a sagittal image of someone's spine. This is an epidural hematoma, and you can see here the spinous processes, and here are the vertebral bodies. These are bright white. Things that are black are air, which doesn't transmit sound waves, and fluid. And here you can see this is the hematoma. And underneath the bone is also black. This is just shadow, because there's nothing underneath that bone to reflect, because the bone has reflected all of it. And what is actually coming out of the ultrasound probe is a credit card thick beam. Okay, so this probe, we're going to go over different types of probe in a second, is curved like that, and it's coming out like that. But in terms of on the side, it's only a credit card thick. So when I think about what image am I seeing, I think about just chopping through the thing that I'm imaging, and that's what I would see, the 2D section. So there are 3 different types of probes, and this is the first confusing thing when you look at an ultrasound probe. Gosh, there's a lot of probes, but actually it's quite simple. There are 3 probes. This one is called the linear probe, and it's obviously linear. This one's the curvilinear, it's curved, and this one's the phased array. So when we're doing ultrasound cannulation, we're going to go with the linear probe. It's often called the vascular probe. The reason being is it's high frequency. That means that your resolution is great. You can look at this image and it looks a lot clearer than this image. But because it's high frequency, it doesn't penetrate that far. Whereas the curvilinear probe, it is low frequency, it penetrates further, but the resolution isn't as good. So that's things like fast scans, looking at the kidneys, the bladder, etc. The high resolution probe would be looking at things like nerves, superficial tissues like the thyroid. And I remember that for, when you're maybe at a music festival and you can hear music in the distance, it's the low frequencies that you can hear because they travel further. It's the, the bass that you hear. You don't hear the high pitch stuff. The phased array probe is the echo probe, and it's because it is small enough to fit in between the rib spaces. So this is quite a busy slide. We're going to talk about ultrasound basics. We're going to go through it bit by bit, so don't worry about, it's quite a busy slide. So number 1, gel. You need gel because gel is an acoustic medium. Sound doesn't go through air, so you need gel, and lots of it. Number 2, you need a probe cover. So you will find some people doing ultrasound cannulation without a probe cover. Don't do it. They'll tell you don't need it. You absolutely need a probe cover. In Edinburgh, there was a patient that got hepatitis from one patient next to him because the ultrasound machine was taken to do a cannula and then another cannula. Blood must be cleaned with the appropriate cleaning solution, and it never is. There is that bucket of chlorine that the nurses make up in the sluice. No one ever seems to go and use it. So please, if you're doing ultrasound cannulation, use a probe cover. You can use an a central line tegaderm. This is a bigger tegaderm than your normal peripheral cannula, but you can see here all of this area could get blood on it. I will show you later about how you can make a sterile glove into a probe cover, but there are now ultrasound condoms that you just use, and you slide them down and put a rubber band around it or a bit of tape, or you can get the big expensive central line covers, and these are like really long plastic sheaths that cover the whole cable. Whatever you're doing, just make sure it's covered up and it's cleaned well. Ergonomics. So when you first start learning how to do ultrasound cannulas, like I did, you will have the machine all the way over there, you'll have the patient here, and you'll be doing this thing where you're turning your head, and that is just going to make you more likely to fail. What you want is the arm directly in front of you and then the screen in front of that, so that you can, it's just a matter of looking up. Orientation. So once you've selected your probe, what you want to do is put some gel on and tap the left side or the right side. And if you see the corresponding image on the ultrasound machine flicker on the left, when you touch the left of the probe, then you know it's correctly orientated. But if the right of the probe, and you can see it here, you're touching the left, it looks like it's being touched. If the right, then you just need to turn it around because it's not oriented correctly. There's a lot of knobs on the ultrasound machine, and they can look intimidating, but they needn't be, because there's only two that you really need to know, and that's depth and gain. So you can't see it that well here, but on this screen there are depth markings and a total depth down here. So let's say this is 2 centimeters, and the markings are going to be 1.5, 1, 0.5, and 0. This is the surface, right? So you can adjust the depth. Maybe what we're looking at is only a centimeter deep, or we can optimize our image by reducing the depth down to, let's say, 1.5. You don't need 10 centimeters of irrelevant space beneath the thing that you're looking for. By reducing the depth, you'll make the target bigger. And then gain is essentially like your brightness and contrast. So you can see here, low gain, high gain, appropriate gain. Sometimes there's an auto gain button that'll do it for you. How to hold your probe. When you first start doing ultrasound, you are probably going to hold it like this. You're going to hold it high up and it's slippy and the probe's going to be moving all over the place. Hold it low down and support your hand and your forearm on the patient. And that allows you to make really small movements, because the small targets that we're looking for, I think of it like when you're playing pool, you don't hover your arm up. You need to be nice and stable. So have a big flat hand resting on the patient and hold the probe low down and make small movements. And lastly, there are apparently 10 different movements that you can make with ultrasound. When you're just getting used to it, you're going to get lost quite easy. So what I would say is try and make one movement at a time. So slide left or slide right, slide up or slide down, tilt or rotate, but don't try and combine them. Also pressure, more or less pressure, also changes your view. Cool. All right, so there are 3 different modes on the ultrasound machine. There's 2D mode, which is what we've just been looking at. There is color Doppler, which we'll talk about in a minute. And then there is something called M mode, and you'll see a big M. M mode, not going to talk about it that much, but just to say that if you press it once, it will give you a line normally in the middle of the screen. And that's quite a handy marker for when you're trying to get used to what is underneath the middle marker on my ultrasound probe. So these correspond. If you press it twice, then you will get this second bit on the bottom. So M mode is essentially looking over time. So you imagine that this is the x-axis, this is time, just in this one line. Not the whole beam, but just this one single tiny crystal on this array of crystals over time. All right, and that can be used to rule in or out pneumothoraces. This is the picture, you've got bone here, rib, and this is pleura, and maybe we can show you that later. But just know that you can press M mode once and you can get this middle marker. It's quite handy. Press it again, you get this, and you don't want that. And you can press 2D and get rid of it again. All right, so the first thing that you're going to look at in the ultrasound workshop is your neck. This is the first thing that we get introduced to as anesthetic trainees when we're using ultrasound to do CVCs. And here you can see the probe has been put on the neck, and the first thing you see is the big IJ and the carotid. This is someone's arm. This is the medial arm. You've got the humerus in the middle. You've got the brachial artery, brachial veins, basilic vein. So this is probably the biggest vein that you'll find in the arm, and all of the IVDUs, they won't know about it. You definitely can't see it because it's at least a centimeter deep, if not more. It's the first one that I'll go to, the first one that the first one that the vascular access nurses will go to. But I want to tell you, and it's repeated here 3 times, that when you are learning ultrasound cannulation, you need to stay well away from the elbow. It may be tempting to go for the basilic, and again, we'll look at that later in the workshop, but there are many things here which are important that you could hit, and until you are comfortable with knowing exactly where your needle is and how to control the needle, you don't want to hit any of these structures accidentally. Okay, so when you are learning, when you're practicing under supervision, stay well away below the ACF. There are still things in the forearm that you could hit. The radial artery, of course, it's the whole forearm, but you're not going to hit the brachial artery, which doesn't have any collaterals. You're not going to hit the median nerve. So stay well away from the elbow. Cool. So the most important thing is being able to differentiate between an artery and a vein. Now, this is a common medical school question, isn't it? Well, how can you differentiate between a vein and an artery? Essentially, it's compressibility and pulsatility. So here you can see an IJ which is compressing and the carotid isn't compressing. It's important to point out that if you don't put any pressure at all, you probably won't see an artery pulsating. It's just like when you try and palpate your own pulse. If you just touch over your radial artery, you don't feel it. If you put a reasonable amount of pressure, you will feel it, and you'll also compress the veins. And if you put loads of pressure, more than 140 millimeters of mercury, then you will compress the vein. So arteries are difficult to compress. Veins compress very easily, is probably what we should say. And pulsatility, so the arteries will be pulsing. Yeah, let's leave it there. If someone had an AV fistula, rarely you could see the vein also pulsating. If they've got a clot in their vein, it will be non-compressible, like I said, but generally arteries are pulsatile and difficult to compress. Just to touch on the color Doppler, so we said about that. Color Doppler is something that can be used to measure velocity as well as direction of flow. So don't be confused by the blue color. When you put the color Doppler mode on, blue does not mean vein. A blue vessel can be an artery, and it's all to do with the Doppler effect. So if you did physics, you'll know this, that as a object is moving towards you, the pitch and the velocity seems to increase, and then as it goes away and it's moving away from you, the pitch goes down. And that's the reason that the ambulance sounds different as it comes towards you and then it goes past you. Yeah. So if you have the probe on the arm and the blood flow is going this way and the probe is facing this way, it's going to be one color. But then if you turn it, it's going to be a different color. So color Doppler is useful for, okay, it really shows you when the color's pulsing. It's obvious if it's pulsing, but the color is not important. So just to be clear, a blue vessel is not a vein. And here is a picture of what the basilic vein and the brachial artery and veins look like. Say that it looks like Mickey Mouse when you look for the brachials. Here is an artery that has been dissected and gone into spasm and then come back. So I have once accidentally put in a cannula into the brachial artery in someone that was really difficult and I think probably a bit hypotensive. All I could see were the brachials, and I put it into the brachial artery, and then I took the needle out and a high pressure jet of bright red blood came out. I think what is important is that you maintain a high degree of suspicion. And in that case, I didn't put anything down it. I stopped, I took a gas. The gas had really high sats, and I thought, okay, it's definitely arterial. And I took it out and the patient was fine. But if you put a needle, especially a big needle, into an artery, you can dissect it and, you could end up in coroner's court. So it's important that you differentiate veins and arteries. You don't put anything down something that you're not sure, and you know where your needle tip is at all times. Touching on extravasation. So we mentioned that ultrasound cannulas are more likely to extravasate. This is important because some drugs are irritant. This is why patients will come to CPOD to get a central line so that they can get a TPN, because TPN is mostly 50% dextrose, which is very irritant. Some other drugs that are irritants are amiodarone, NORAD, calcium chloride. When we talk about hyperkalemic management, talk about giving 10 mils, 10% calcium chloride. Well, that's an emergency. But generally, if we just needed to give calcium, we would give calcium gluconate because it's less irritant. But calcium gluconate has got 3 times less calcium in it. So if you're going to use calcium gluconate rather than calcium chloride being the one that you find in your rest trolley, calcium gluconate is just in the drug cupboard. You need to give 3 times more, 30 mils of 10% calcium gluconate. Yeah. Anyway, So onto the actual technique. So we've got two slides here. Let's firstly talk about the one on the right, the 10-5-3 rule. So there's a study that showed that it was in the EMJ, sorry, Emergency Medicine Journal, that the likelihood of the cannula tissuing depends on the amount of cannula plastic that is actually in the vein. Remember, you've got to go through the skin, subcut tissue, and then you've got to leave a little bit of plastic in. So that plastic is going to be partly in the vein, partly in the tissue. And the more cannula that you leave in the vein, the less likely it is to tissue. Really, when it's tissued, when they move their arm, the plastic that's in the vein can just pop out of the vein. So why is this important? They showed that if they had more than 60% of that cannula's length in the vein, then none of them tissued after a set period of time. This is important to us because it's going to dictate what length of cannula we need to use and what's the deepest vein that we can go for. If you've got a 4 centimeter long cannula, which is the green, which is my first tip for you, only use green cannulas. Greens are longer than blues and pinks, and that is important for us for the reason mentioned. If, let's say, we went for a vessel which is 4 centimeters deep and we went straight down, well, obviously that's going to tissue straight away. So using some maths, we can say that if we want to have at least 50% of the cannula in the vein, the very max depth that you should go for with a green cannula is 1.5 centimeters, 15 millimeters deep. So that brings us on to the 10-5-3 rule, that the vein that you're looking for, the ideal vein, is 10 millimeters deep, 5 millimeters wide, and 3 millimeters long. It should be straight and not have any clot in it. I think this last bit is difficult to measure with ultrasound, so I just think of the 10-5 rule. I set my depth to about 2 centimeters, and I'm looking along the 1 centimeter for veins that are, deep enough that I can hit them. Very shallow veins are actually more difficult to hit with ultrasound, and very, very deep veins, more than 15 millimeters deep, you can get them, and you can leave a tiny bit of plastic in, but they're just going to tissue a minute later. You'll feel chuffed, and then you'll leave the patient and they'll tissue. What was the point? So 1.5 centimeters deep is the absolute maximum, but ideally 10-5 rule. Okay. So moving on to how do we actually do it? So we found our vessel. Let's say that it is 1 centimeter deep. What you're going to do is insert the needle 1 centimeter back from where the probe is, and you go in at a 45-degree angle. And you can see here that if you just kept the probe there and you went in at 45-degree angle, 1 centimeter back, it's 1 centimeter deep, that your needle, if you were exactly 45 degrees, would appear on your target, right? So just maths. So come back as far as it is deep and insert 45 degrees, and you should hit your target where you were looking at. So there are 2 different ways to look at your vessel and needle under ultrasound. These are in plane and out of plane. The reason that this is important is it is important to know exactly where your needle is at all times, so you don't hit a structure that you weren't intending to hit. So the one that I'm going to advocate for you to learn initially is the out of plane. So here you can see, let's look at in plane first. So you can see that the vessel is in the same plane as the beam, and you get this sort of horizontal, you get this side-on view of the vein, and you also see the whole needle at all times. So this is great, and this is the technique that we use when we're doing regional ultrasound in anesthesia. However, it is difficult because you have to align the needle with the very thin beam on slippery surface, and you're not looking at your probe and your needle, you're looking at the screen. It's very difficult. Okay, so I would advise you not to use this technique. Use out of plane instead. So out of plane sort of transects the vein, and all you'll see is the lumen, and you also transect your needle. So this is easier. However, it comes with the risk of mistaking the dot that you're seeing for the tip when it is in fact the shaft. So if you look at the bottom image here, you can see on the right, this is the needle tip and it appears as a dot. However, the shaft is just going to look like a dot as well. So the question is, is the dot that I'm seeing, is it the shaft or the tip? So we're going to talk about that in a minute, about how you can find your needle tip. It's obvious when you're in plane where the needle tip is, but it's not so obvious when you're out of plane. But this is the easier technique. So how do we find our needle tip? And this is, I think, yeah, this is the last slide on technique. So what we're going to teach you is, and this is what you're going to come and practice in the ultrasound workshop, is the vanishing target technique. Let's say that you found your vessel and you came a centimeter back and centimeter deep. You'll see some people just hold the probe still, and then they will put the needle in and hope that it appears where they're looking. And let's call that a static technique. What I think that you should try and do, which is much safer, is to use the dynamic technique in out of plane or short axis. So dynamic short axis just sounds like a mouthful. So we're calling it the vanishing target technique. So here's what you're going to do, and you're going to see it in a moment in one of the videos, is you're going to puncture the skin. So you just get the needle like 1 millimeter or 2 millimeters into the skin. It's nowhere near any of the targets that you want, so that's fine. And then you lift up the probe and you come back to the needle, and then you find your needle tip. So when you first start doing ultrasound cannulation, I think the trickiest thing is finding your needle initially amongst all of this noise. And that's what you're going to practice as well. And I think the easiest way to do that is, once you've put the needle in, so needle's in, you've got your probe here, you lift up your probe and you come back to where you definitely know the needle is. So I put the probe on top of the needle, and then you'll see the shadow at the top of the screen. You see this really bright spot and you think, aha, there's my needle. And now what you need to do, let's say that this is the needle and I've come back up to here, and aha, is you slide down and all you see is a dot. You see a dot, you see a dot, you see a dot, until the dot disappears, and you come back. Once it comes back, that is the needle tip, right? By definition, you've slid all the way down here, and that is where the needle tip is. So puncture, pause, find your needle tip. Now we're at number 2, and this is when we start doing the vanishing target technique. So what you're going to do is move one thing or the other. You move the probe forward until you lose the dot. Here you can see the dot. The needle is staying still, but the probe is moving forward. Yeah, probes move forward, and now we can't see the needle tip anymore. The dot has vanished. And now we're going to hold the probe still and move the needle forward until the dot reappears. So by doing this, and you're only going to move the probe forward like a couple of millimeters, and then the needle a couple of millimeters, you always know exactly where your needle tip is, and that is how to keep safe. You've looked at the arm, you've seen where the important things are, you know where your target is, and then you're going to initially put your needle in only a couple of millimeters, then you're going to find it, and then you're going to follow it all the way down until you get to the vessel. And then, as you're going to see in the next video, by threading the needle all the way up the vein, we can ensure that we've got a lot of that plastic cannula inside the vein, and you can actually hub the entire needle inside the vein using this vanishing target. Now we're trying to keep the dot inside the middle as well. All right, so we're going to watch a video of that now. The link's here if you want to look at it later. I'm going to pause the video and talk through it. So this is my arm. I don't have a very big arm. And so you can see here the depth is 1.5 centimeters. Here are the graduations. So this vessel, this is my basilic vein, is 5 millimeters deep, and it is easily more than 5 millimeters across. So it satisfies our 10-5 rule. And I think down here is a nerve. So nerves, if you think about when you're measuring out spaghetti, and you pick up the spaghetti and you look at it side on, you'll see all these dots like bundles, and that is what a nerve is essentially. It's just a bundle of fibers, isn't it? So that's a nerve there. This is basilic, and you can see the needle just appears here. It's this bright dot. Yep, you see it come in. And so what Sophie's going to do now is reposition and move it down you can see here the needle is sort of like tenting my vein, and you can actually feel this. You can feel the resistance to the needle, and then it pops through into the vein. This, at the moment, the needle is not inside the vessel. I know it looks like it is. This is just sort of like an acoustic trick from the ultrasound. Okay, now it's inside. And what she's going to do is the vanishing target technique. Although she's doing it very quickly because Sophie's very adept with ultrasound cannulation, this was actually her doing it slowly. And that final movement you saw at the end there, that's just her threading the plastic. All right. So how do we confirm that it's in? So once your needle's out, you can actually look at the plastic cannula and see that it is inside the vein. Here's our out of plane technique, and it's this bullseye. That is actually the plastic cannula, it's not the needle. Same here, if you look at it in plane, you can actually see the cannula coming in from the skin, and it's actually within the vein. That's pretty cool. If you've taken your needle out and then you try and aspirate and you've still got your tourniquet on, you should be able to aspirate blood, and when you take your needle out, it should bleed everywhere if you've got your tourniquet on. If it hasn't, I'm afraid to say you are not in the vein. And I learned that, unfortunately. It's going to take you 5 or 10 times of trying on a real person before you start getting comfortable and confident doing this technique, and you'll convince yourself, oh, I was in the vein. And if you can't see it and it's not bleeding, you're not in the vein. Sorry. And then finally, you can put a flush down it. So this is what normal tissue looks like. This is what edema looks like. If you've just bolused 10 mils of fluid down and suddenly you've got edema, well, this is just because the fluid has ended up in the tissue planes. And then lastly, there's this technique called the saline agitation technique. This is a bubble echo. So a bubble echo is where they inject air into the heart and see if it crosses across through a PFO. And you can see here, air bubbles are quite echogenic. Now, I know that contradicts what I said earlier about air not reflecting sound waves, so I don't know why. I guess it's a change in density is a reason it appears here. Anyway, when you use a PosiFlush, there'll be a little bit of air in it, and so when you inject down, you'll suddenly see all of these agitated air bubbles in the vein, if you're in the vein. So to summarize, we talked about ultrasound physics, the benefits, different probe types, how you can orientate your probe, how you can change the depth, the gain, what end mode is, the fact that you need gel, you need a probe cover, pay attention to your ergonomics. We didn't talk about lidocaine. I don't think that you need lidocaine for a green cannula anymore. You'll see me use it in the next video. I would definitely use lidocaine for a gray or an orange though. We talked about factors that affect flow rates, why you would use an IO, the fact that you need to obey the 10-5 rule and not put anything that is going to be bad if you extravasate, how you can differentiate arteries from veins and nerves, the fact that on color Doppler is just about direction. It's not about, blue can be an artery. In fact, when you look at an artery, it will generally be a mixture of colors because there's some turbulent flow. We talked about the preferred method, which is the out of plane technique, the vanishing point, and how you can confirm. And now we're going to talk about needling practice and phantoms. But before we do that, we're just going to look at a 5-minute video, which hopefully will consolidate everything that we've learned. So this is an equipment list. If you want to come back to this video, the link is there. You can watch it in your own time. So first things first, I have made Sophie comfortable by putting a towel underneath her arm. I'm now going to check. Yeah, there you see me touch the side of it. I'm just looking at my orientation. First of all, I haven't cleaned. I'm just scanning the arm, trying to find a nice vein. This isn't a great video. There's many things that I would change. we get the screen closer. You'll see the screen closer in a minute. So I'm just optimizing the image by changing the depth, maybe changing the gain, putting some more gel on. You can see the vessel here, which is collapsing and found a nice vein. This is just about the 10-5 rule. This is an example of color Doppler. So you can see here that this is not pulsating and it's blue. So that's a vein and it's collapsible. And these two vessels here, they are pulsating. One of them is red, one of them is blue. They're both arteries. So these are it must be brachial arteries. It must have bifurcated or something like that. So I'm marking with a cap, and then I'm putting a sterile barrier down, and I didn't show it, but because you've got to scan quite a wide area, I normally clean a very large area. So I'll take one of the chloropet lollies and I'll just scrub the whole arm. I've used a bit of lidocaine. You'd be surprised at the amount of lidocaine that you need to make a cannulation attempt much more comfortable. So, you know, I will put like 0.1 of a million when I'm doing a grey cannula, and they barely feel it. So here is an example about how to make a sterile probe cover out of a sterile glove. I would recommend you just use the condom or the CVC probe cover now, but if you need to, you don't have any of those things, here's how you can make it. So you put your probe somewhere that's steady, so just put it in the machine, get your sterile gloves. Inside the glove is still sterile. You stretch it over your probe. And then you pull it tight because you don't want any air. And then you tape it up. And hey presto, you've got yourself a cheap sterile probe cover. And then you need to put more gel on top of that. So you've got gel underneath and gel on top. Just a word about ergonomics. So not practicing what I'm preaching here, really this machine should be over here in line with Sophie's arm. But I am making myself comfortable by getting down to the right height, and I'm also talking about moving the screen, just checking that she's numb. And now we're going to see the technique about putting the needle in, coming up with the probe, back to the needle, finding the needle, and then doing the vanishing target technique. And you don't really see it that well on the screen, but the needle comes in to the right of the vein, and then what I have to do is readjust by changing my angle. Oops. All right, you see me moving the needle tip closer and closer to the vein, doing the vanishing target technique. And now it's punctured the vein and it's inside the lumen. And I'm just going to continue the vanishing target technique as I try to get all of the needle inside the vein. And I'm trying to stay center. You can see that the vein gets a bit bigger there at the end when I stop putting pressure on it. Importantly, once you've got the whole needle in, well, you don't need the whole needle in, but I think it's easier, is that you need to dry the arm thoroughly, because all of that gel is going to stop your tegaderm from sticking. pressure and a bit of gauze underneath the cannula will prevent you from making a mess, especially if it's a big vein. And that's it. Here we are confirming, just like we said. So here's the bullseye with the vein and the cannula. And then we're swapping over to the in-plane technique. It's a bit tricky to do, but there you go. There you've got the plastic cannula inside the vein. And this is another example that we recorded. And some credits. Thank you to everyone that helped me. Cool. All right, finishing up. So how can you practice your needling technique? You can practice on DIY phantoms. So you can make a DIY phantom out of pork gelatin. There are plenty of recipes on the internet, and then you need to put something inside it. You can see here they've used balloons. I used endotracheal tube when I first learned, but you can't puncture them. Friend of mine, Jamie, he used some pasta, so he half boiled some, I think penne, and that's good. It's a lumen that you can see, and then you can puncture them. One time I used chicken breast. Pork gelatin has got the same density when it cools and solidifies as human tissue, so it's great. Chicken breast looked amazing on ultrasound because it's just muscle. However, a bit unsanitary, so I wouldn't recommend that. But fortunately at Darrant Valley, there was a GP trainee here last year that taught ultrasound cannulation, and she acquired the ultrasound machine, which is on Chestnut, which is there for difficult cannulation through charity. She also got these expensive blue phantoms. They're like £600 each. And so that's what you're going to use. You use one of these two when you come down to practice with us in our ultrasound cannulation workshops, but you can also request to practice on them in your own time by booking via the MedEd simulation team. So here's their email address, or you can call them 5799. It's important that they are expensive and they require care, so we'll send some instructions on what you need to do to look after them. So last slide, this is what you're going to do when you come down to practice, and I'll leave it there. Thanks very much for listening. I hope it's useful. No, it will be useful, and you're going to come down and practice, and you're going to learn how to do ultrasound cannulation. And if you see me and you thought that, if you see me and you start putting in ultrasound cannulations, I want to know, because I'll be dead chuffed. And lastly, if you could leave some feedback on this video so we can know how to improve it, and also the ultrasound cannulation workshops. Very much appreciated. Best of luck. Cheers.